Thank you very much for the introduction. Congratulations for the BICC on an excellent conference. It's quite delighted to see how much is going on over these days. Dear colleagues, it's a great honor and delight to really give you the advances in management of hepatocellular carcinoma from biology to bedside. And I have to start by saying it's really an awakening and rather a surprise that the medical oncologist will be the first speaker in an HCC case. Actually, in the past, we didn't even talk because we didn't have much to say. But nonetheless, it's really a delight to see how much we can contribute. And really all, as we just heard from our chair, is a joint effort and collaborative effort as a teamwork with the other experts. With this, I'll just present my disclosures over here. And also, these are my contacts. And please feel free to connect with me at any time. My contacts are readily available through the BICC, but at the same time, if you'd like to take a picture of the QR code, you'll connect with me. And as many of you know and have seen before, always happy to answer any clinical question, of course, any research question and education question, especially for all the young trainees and fellows and residents. So with this said, I'm going to jump on through a couple of components, and my colleagues will appreciate that I touch on liver function, the target therapy for biopsies. We'll talk, of course, at length systemic therapy and etiology, but we'll go back to local advanced disease because, yes, medical oncologists can have a role there. And lastly, we'll question access to therapy. That's an important component of where do we serve the world in regard to those new advanced therapies. In regard to liver function, please remember one thing. The Child-Pugh scoring that we really depend on was not really destined or intended for the evaluation of the liver functionality in liver cancer. It was a study back in 1973 by Dr. Pugh, or Sir Pugh, because he's Mr. Pugh because he was a surgeon in England. The idea was, who is at risk for varices that can bleed? All of them actually had cirrhosis, but none of them had HCC. Why did we settle to this? Because frankly, we did not agree to anything else. So just let's make sure that we take off any voodoo in regard to why we're doing the Child-Pugh, but let's live with it because all our clinical trials are based on the Child-Pugh, and we are really destined to look into this. No need to go over the details, but please remember there's a sequence of events in regard to how this occurs. Albumin followed by bilirubin, ascites, which is a clinical ascites, encephalopathy, which is a clinical encephalopathy, and PTINR. It's not like a flavor, I have this or I have that. It's really that sequence that we really expect in that regard. And more importantly, the sequence leads to an exponential curve. This is not a linear curve. Patients live on a Child-Pugh A from DECA around the world back to DECA, and they're still Child-Pugh A, and then the curve into B, and then the shoot into C. And our job, of course, to keep patients at B, at A as much as we can, so we can serve them best. Now, if you ask me, is this really the best option to really treat liver cancer and assess liver cancer? Probably not. I would give credit here for Dr. Johnson in regard to the ALBI scoring, which really is rather more complex to look because you probably at least have some instrumentation, but they are available for us as apps. And at least I recommend for the clinical trial coming forward, make sure beside the Child-Pugh have the ALBI score. So hopefully with this joint effort that we all do, we'll hopefully be transitioning all of us to the ALBI scoring, which is more detailed and probably more accurate in regard to the assessing whole liver function. Now, with this said, the other point I would like to touch on before I deal to the meat of the matter is the target therapy and biopsies. And this is a big subject that comes along at many conferences right and left. And let me take a little bit back in history. When Jordi Bruges, back in the BCLC in Barcelona, brought in the idea that, you know what, if we're screening patients for potential liver cancer, we can look at the liver and we can see if this little lesion or that little nodule is probably disease or not. We can save ourselves a lot of biopsies. And we took it as a granted that we can just look at diagnose HCC by looking at imaging. Then carried on, Claude Serlin from UCSD and his group built in what's called the LIRAD system, which is like radiology for liver cancer. And if anything, they really have assessed that they found a correlation between certain descriptors in regard to the tumor, that how it looks on the imaging, and they will be say, okay, this is liver cancer or not liver cancer. Very important to remember that about close to 85% of the tumors that are local or locally advanced only, yes, probably it's reliable in 80 up to 85% of the cases. But when it comes to systemic therapy and systemic disease, it has never been tested. And here I like to quote three words that, or three sentences Dr. Serlin brought in at the ILCA back in September of 2022 in Madrid, where he said, we do not have the data for evaluating and applying LIRAD in regard to advanced HCC. So please, 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 if you really want to treat somebody with systemic therapy, you need to do a biopsy. And you will be amazed how many times you'll be wrong in regard that this is not HCC. If it comes to a surgical resection, I totally understand. This is really where entrusted surgeons, they know better, and they will definitely be able to apply it without any intervention. In regard to local therapy, yes, as well. But when it comes to systemic therapy, you need the biopsy as well. Now, I really don't know much about really the legal system in Bangladesh or in many parts of the world, but I'm not aware why or surprised why Dr. Serlin, when he was talking, said medical legal concerns are in my subconscious only. And I was wondering, why did he broke it up? So I went ahead, and it just happened that I'm a lawyer as well. So I just searched the medical system and legal system in the US. And in 2022 alone, there were 2 cases that went in court because it was misdiagnosed. And what was the diagnosis? As many of you have guessed, it was cholangiocarcinoma. And as such, please don't want to go into that route. It's not how we think, all of us. We don't operate that way. But definitely we don't want but to make sure that we ensure a patient is really treated correctly. And lastly, he said something rather cynical. And he said, oh, can you tell me about target therapy in HCC? And I said, well, you have to probably ask us. Because if anything, this is some of the early effort that we did at Memorial Sloan Kettering in New York, where we looked at the genetic alteration in regard to HCC. Why we're not really able to delineate more than through 3 pathways that are a little bit crude, not really very specific, the WNET pathway, the P53, and at the same time, the other, we call it the other because we know more, is because we don't have that much tissue. The more tissue we have, the more we are able to delineate how to really be able to not only diagnose, confirm diagnosis, but at the same time be able to really see how we can address targeted therapy in the future. So, with those 2 points, I would like now to touch on systemic therapy. And I have to tell you, I've been doing the HCC for like 25 years. And I'll tell you, when I started, there was nothing we can offer. We used to call everybody and send them to our dear surgeons who are really in the front row over here. And nowadays, we really got an understanding better about the rather very angry immune environment if the liver cancer in the liver. Enough that we depend a lot on the immune cycle over here, and pretty much we depend specifically at point number 7, what we call anti-PD-1, anti-PD-L1. I always like to describe this to our patients because please do use this kind of descriptors for patients, or your imagination can take you in way better routes as well, is that T cells come to attack the cancer cell, same as T cells will attack any virus, any bacteria, but there's a certain agreement that come upon between the cancer cell and the T cells, enough that it will offer a chair, the cancer cell, to those T cells, have a seat, don't touch us, we will not bug you. And this is exactly how we're protected by this chair called PD-1. And what do we do when we give anti-PD-1 immunotherapy? We simply kick that chair out, so as such, those T cells will drop onto the cancer cells. However, we all learned, and I can guarantee you, all of you, wherever you work, at whatever institution, whatever hospital, if you want to change any chair or any desk in your office, you have to call the boss. And the same thing in the immune system, there's bosses. And if anything, at point number 5, you see it halfway at 3 o'clock, this is where the anti-VEGF come to play. Think about the anti-VEGF as being like a mid-level manager. This is a person who really routes around the floor, make sure everybody's doing the right thing in the factory, and we need to make sure they are there all the time. But interestingly, you also have a CEO in every company, and this is at point number 3, which is CTLA-4, where really actually it happened in the lymph node, where, as we know, if the CEO send one letter saying do this or kick that chair out, guess what? They'll send only one letter. And this really was important. It's given only once. So let's dissect a little bit of these. What do they mean in regard to therapy? And I'll start by the one which really has been most commonly used and I assume to be the only standard of care, simply because they were the first into the intervention, the IMbrave 150, looking into atezolizumab plus bevacizumab. Survival ultimately translated to about 19 months for the combination compared to about 13 months for the sorafenib. 2 important points over here. The first one, please, this is more important as a safety message. If you decide to do atezolizumab, bevacizumab, make sure you scope the patients. Because with the anti-angiogenic, the anti-VEGF, people can bleed. And guess what? They can bleed to death. And if anything, make sure you scope them. Don't ever take it lightly. Oh, that's not bad patient, because you know where bad things happen when you don't want them to happen. So please always scope the patient. Now, however, that 19-month, let's hold on a little bit of thought for a second, because we're going to show the other data, and I will urge you how to analyze this comparator work. This is a Himalaya study. We probably led this from Memorial Sloan Kettering all over the world. This is the largest study ever done in liver cancer, 1,200 patients. And we looked at combination of two immunotherapies, anti-PD-L1, remember the chair kicking out, and anti-CTLA-4, the boss telling the chair out. The mean survival was 16.43 months compared to 13 for sorafenib. And of course, all of you are already posing, say, well, wait a minute. You are trying to tell us that this 16 months is better than 19. 19 is a higher number. You're right, but hold your thought over here for a sec, because I can also take it the other way around. With the CARE-310 study that came from China that looked into camrelizumab plus rivoceranib, anti-VEGF plus anti-PD-1, guess what? Median survival 22 months, even better than 19 of the AMBRAVE 150. What's happening here? Interestingly, a nice retrospective study was done by our colleagues in University College London, and they looked at what's called the AB real study. A stands for atezolizumab, B bevacizumab, real world data study. And they found that actually the mean survival for the atezolizumab, bevacizumab is not 19, it's 15 months. Was somebody wrong here? Like, did they do something? Not really. But all depends, and this is really always the message, ask who are the patients of those studies. Because all what I can tell you is that in the ABL study, close to 30% of patients were Hep B, while in the AMBRAVE 150 itself, 50% of the patients were Hep B. And interestingly, Dr. David Pfister brought us to the Nature paper from 2021, you might recall that, where actually it was shown that when you have a more presence of Hep B, the checkpointers will work better. Why is that? There is a certain component of CD8s that will be enticed by the Hep B infection that will really lead to an improvement. And as such, you can see with the AMBRAVE 150, with, as you see all the way at the bottom, 50% of the patient were Hep B. If you go to the Himalaya, halfway, 30% were Hep B. And if you go to the CARE-310, you see it right in the middle, 75% were Hep B. So altogether, we can think of whenever we have more Hep B, survival goes up. Less Hep B, survival go down. Well, great, we fixed it. Well, not really. Hold your thought. So if anything, interestingly, then a kind of like came to us from the left field, the Checkmate 90W, looking at ipilimumab plus nivolumab, which again, two checkpoint inhibitors, same thing, anti-CTLA-4 plus anti-PD-1. And it showed versus sorafenib lenvatinib a survival which is impressively close to about 24 months. But at the same time, we see that there are only 30% of people who are Hep B. So what's going on over here? Clearly, we discover there are more variables than we can think of that really can contribute to that part. And we have shown that already ourselves in our first phase 2 study that led to the Himalaya study, as you can see over here, with a higher CD8 cell population, low CD4 cell population, which really can add on to that exhausted CD8 cells. We found that actually there's a third variable, which is TOX, T-O-X, which you can see here kind of like inflicting into the tumor. And this, by the way, what led to the Nobel Prize this year with the FOXP3 as a regulator. So we don't think anymore it's only one variable or two. We think about it as being like more a combination of variables. And this is what we're working at the moment. We actually have great effort happening all over the world. We have cohorts of patients from Korea. We have cohorts of patients from India. We have cohorts of patients from the Pacific, because the Pacific has a lot of liver cancer. We have cohorts from Canada, from France, and from New York City. And we are really trying to understand better who would respond to a therapy. So we really jump on to that percent chance statistics to really, you'll get that therapy because this is your makeup of the tumor environment. And that's really what really led us ultimately to an incredible improvement in survival. As we can see over here, proudly, this is the only first time that we see 5-year survival data on HCC in liver cancer. Admittedly, I've never seen that before. Actually, I should update that slide. I just came already from Berlin last week, and we reported 6-year survival data. We have close to about 18% or about 20% of the patients alive at 5 years. Numbers we were never heard of in regard to liver cancer, in regard to advanced and systemic therapy. With this said, I stop here and happy to answer any questions as per the chairs. Thank you very much.